Heart failure part 2. Heart failure results from a variety of cardiovascular conditions, including chronic hypertension, coronary artery disease, and valvular disease. 1. As HF develops, the body activates neurohormonal compensatory mechanisms. 2. Systolic HF results in decreased blood volume being ejected from the ventricle. 3. The sympathetic nervous system is then stimulated to release epinephrine and norepinephrine. 4. Decrease in renal perfusion causes renin release, and then promotes the formation of angiotensin I. 5. Angiotensin I is converted to angiotensin II by ACE, which constricts the blood vessels and stimulates aldosterone release that causes sodium and fluid retention. 6. There is a reduction in the contractility of the muscle fibers of the heart as the workload increases. 7. Compensation. 7. The heart compensates for the increased workload by increasing the thickness of the heart muscle. Causes. Systemic diseases are usually one of the most common causes of heart failure. 1. Coronary artery disease. 1. Atherosclerosis of the coronary arteries is the primary cause of HF, and coronary artery disease is found in more than 60% of the patients with HF. 2. Ischemia. 2. Ischemia deprives heart cells of oxygen and leads to acidosis from the accumulation of lactic acid. 3. Cardiomyopathy. 3. HF due to cardiomyopathy is usually chronic and progressive. 4. Systemic or pulmonary hypertension. 4. Increase in afterload results from hypertension, which increases the workload of the heart and leads to hypertrophy of myocardial muscle fibers. 5. Valvular heart disease. 5. Blood has increasing difficulty moving forward, increasing pressure within the heart and increasing cardiac workload. Clinical manifestations. The clinical manifestations produced why the different types of HF are similar and therefore do not assist in differentiating the types of HF. The signs and symptoms can be related to the ventricle affected. From cardiovascular mnemonics. Left-sided HF. 1. Dyspnea or shortness of breath may be precipitated by minimal to moderate activity. 2. Cough. 2. The cough associated with left ventricular failure is initially dry and nonproductive. 3. Pulmonary crackles. 3. B-bacillar crackles are detected earlier, and as it worsens, crackles can be auscultated across all lung fields. 4. Low oxygen saturation levels. 4. Oxygen saturation may decrease because of increased pulmonary pressures. From cardiovascular mnemonics. Right-sided HF. 1. Enlargement of the liver result from venous engorgement of the liver. 2. Accumulation of fluid in the peritoneal cavity may increase pressure on the stomach and intestines and cause gastrointestinal distress. 3. Loss of appetite results from venous engorgement and venous stasis within the abdominal organs. Prevention. Prevention of heart failure mainly lies in lifestyle management. 1. Healthy diet. 1. Avoiding intake of fatty and salty foods greatly improves the cardiovascular health of an individual. 2. Engaging in cardiovascular exercises thrice a week could keep the cardiovascular system up and running smoothly. 3. Smoking cessation. 3. Nicotine causes vasoconstriction that increases the pressure along the vessels. Complications. Many potential problems associated with HF therapy relate to the use of diuretics. 1. Hypokalemia. 1. Excessive and repeated diuresis can lead to hypokalemia. 2. Hyperkalemia. 2. Hyperkalemia may occur with the use of ACE inhibitors, ARBs, or spironolactone. 3. Prolonged diuretic therapy might lead to hyponatremia and result in disorientation, fatigue, apprehension, weakness, and muscle cramps. 4. Dehydration and hypotension. 4. Volume depletion from excessive fluid loss may lead to dehydration and hypotension. Assessment and diagnostic findings. HF may go undetected until the patient presents with signs and symptoms of pulmonary and peripheral edema. 1. ECG, ventricular or atrial hypertrophy, axis deviation, ischemia, and damage patterns may be present. 1. Dysrhythmias, for example, tachycardia, atrial fibrillation, conduction delays, especially left bundle branch block, frequent premature ventricular contractions, PVCs, may be present. 1. Persistent SDT segment abnormalities and decreased QRS amplitude may be present. 2. Chest X-ray may show enlarged cardiac shadow, reflecting chamber dilation/hypertrophy, or changes in blood vessels, reflecting increased pulmonary pressure. 2. Abnormal contour, for example, bulging of left cardiac border, may suggest ventricular aneurysm. 3. Sonograms, echocardiography, Doppler and transesophageal echocardiography, may reveal enlarged chamber dimensions, alterations in valvular function/structure, the degrees of ventricular dilation and dysfunction. 4. Heart scan, multigated acquisition, MUGA, measures cardiac volume during both systole and diastole, measures ejection fraction, and estimates wall motion. 5. Exercise or pharmacological stress myocardial perfusion, for example, Persantine or thallium scan, determines presence of myocardial ischemia and wall motion abnormalities. 6. Positron emission tomography, PET, scan, sensitive test for evaluation of myocardial ischemia/detecting viable myocardium. 7. Cardiac catheterization, abnormal pressures are indicative and help differentiate right versus left-sided heart failure, as well as valve stenosis or insufficiency. 7. Also assesses patency of coronary arteries. 7. Contrast injected into the ventricles reveals abnormal size and ejection fraction/altered contractility. 7. Transvenous endomyocardial biopsy may be useful in some patients to determine the underlying disorder, such as myocarditis or amyloidosis. 8. Liver enzymes, elevated in liver congestion/failure. 9. Digoxin and other cardiac drug levels, determine therapeutic range and correlate with patient response. 10. Bleeding and clotting times, determine therapeutic range, identify those at risk for excessive clot formation. 11. Electrolytes, may be altered because of fluid shifts/decreased renal function, diuretic therapy. 12. Pulse oximetry, oxygen saturation may be low, especially when acute HF is imposed on chronic obstructive pulmonary disease, COPD, or chronic HF. 13. Arterial blood gases, ABGs, left ventricular failure is characterized by mild respiratory alkalosis, early, or hypoxemia with an increased PiCO2, late. 14. Bun/creatinine, elevated bun suggests decreased renal perfusion. 14. Elevation of both bun and creatinine is indicative of renal failure. 15. Serum albumin/transferrin may be decreased as a result of reduced protein intake or reduced protein synthesis in congested liver. 16. Complete blood count, CBC, may reveal anemia, polycythemia, or dilutional changes indicating water retention. 16. Levels of white blood cells, WBCs, may be elevated, reflecting recent/acute ME, pericarditis, or other inflammatory or infectious states. 17. ESR, may be elevated, indicating acute inflammatory reaction. 18. Thyroid studies, increased thyroid activity suggests thyroid hyperactivity as precipitator of HF. Medical management. The overall goals of management of HF are to relieve patient symptoms, to improve functional status and quality of life, and to extend survival. Pharmacologic therapy. 1. ACE inhibitors. 1. ACE inhibitors slow the progression of HF, improve exercise tolerance, decrease the number of hospitalizations for HF, and promote vasodilation and diuresis by decreasing afterload and preload. 2. Angiotensin II receptor blockers. 2. ARBs block the conversion of angiotensin I at the angiotensin II receptor and cause decreased blood pressure, decrease systemic vascular resistance, and improve cardiac output. 3. Beta blockers. 3. Beta blockers reduce the adverse effects from the constant stimulation of the sympathetic nervous system. 4. Diuretics. 4. Diuretics are prescribed to remove excess extracellular fluid by increasing the rate of urine produced in patients with signs and symptoms of fluid overload. 5. Calcium channel blockers. 5. CCBs cause vasodilation, reducing systemic vascular resistance but contraindicated in patients with systolic HF. Nutritional therapy. 1. Sodium restriction. 1. A low-sodium diet of 2 to 3 grams/day reduces fluid retention and the symptoms of peripheral and pulmonary congestion, and decrease the amount of circulating blood volume, which decreases myocardial work. 2. Patient compliance. 2. Patient compliance is important because dietary indiscretions may result in severe exacerbations of HF requiring hospitalizations. Nursing management. Despite advances in the treatment of HF, morbidity and mortality remains high. Nurses have a major impact on outcomes for patients with HF. Nursing assessment. The nursing assessment for the patient with HF focuses on observing for the effectiveness of therapy and for the patient's ability to understand and implement self-management strategies. Health history. 1. Assess the signs and symptoms such as dyspnea, shortness of breath, fatigue, and edema. 2. Assess for sleep disturbances, especially sleep suddenly interrupted by shortness of breath. 3. Explore the patient's understanding of HF, self-management strategies, and the ability and willingness to adhere to those strategies. Physical examination. 1. Auscultate the lungs for presence of crackles and wheezes. 2. Auscultate the heart for the presence of an S3 heart sound. 3. Assess JVD for presence of distension. 4. Evaluate the sensorium and level of consciousness. 5. Assess the dependent parts of the patient's body for perfusion and edema. 6. Assess the liver for hepatojugular reflux. 7. Measure the urinary output carefully to establish a baseline against which to assess the effectiveness of diuretic therapy. 8. Weigh the patient daily in the hospital or at home. Nursing interventions. Nursing interventions for a patient with HF focuses on management of the patient's activities and fluid intake. 1. Promoting activity tolerance. 1. A total of 30 minutes of physical activity every day should be encouraged, and the nurse and the physician should collaborate to develop a schedule that promotes pacing and prioritization of activities. 2. Managing fluid volume. 2. The patient's fluid status should be monitored closely, auscultating the lungs, monitoring daily body weight, and assisting the patient to adhere to a low-sodium diet. 3. Controlling anxiety. 3. When the patient exhibits anxiety, the nurse should promote physical comfort and provide psychological support, and begin teaching ways to control anxiety and avoid anxiety-provoking situations. 4. Minimizing powerlessness. 4. Encourage the patient to verbalize their concerns and provide the patient with decision-making opportunities. Evaluation. For the expected patient outcomes, the following are evaluated. 1. Demonstration of tolerance for increased activity. 2. Maintenance of fluid balance. 3. Less anxiety. 4. Decide soundly regarding care and treatment. 5. Adherence to self-care regimen. Discharge and home care guidelines. The nurse should provide education and involve the patient in the therapeutic regimen. 1. Patient education. 1. Teach the patient and their families about medication management, low-sodium diets, activity and exercise recommendations, smoking cessation, and learning to recognize the signs and symptoms of worsening HF. 2. Encourage the patient and their families to ask questions so that information can be clarified and understanding enhanced. Discharge goals. 1. Cardiac output adequate for individual needs. 2. Complications prevented/resolved. 3. Optimum level of activity/functioning attained. 4. Disease process/prognosis and therapeutic regimen understood. 5. Plan in place to meet needs after discharge.